What's up, guys? Episode number 4 coming at you from the Bay of Fundy here in New Brunswick. As usual, huge shout out to all the sponsors. I keep saying it, it's expensive, and I didn't want to pay for it all. And these guys really helped me. So their dedication to spreading the word is a reflection of how good of human beings they are and how good their businesses are. So once again, thank you to them. The Stellate Ganglion Block. Whew. What is it? That's what I said when I first heard about it. Just like a lot of these treatment modalities, just like you, wondering, what's that? And it's happening where? And it's doing what? And it has these amazing, effective results. Yeah, I can dig it. I can dig it. So that is something I 100% wanted to bring to you guys. We'll backtrack, and I don't have very much experience with the Stellate Ganglion Block, so I'm just going to take the time to tell you guys what's going on with webinars and what kind of effect it's actually happening in the real world, other than bringing you guys the gospel and the good word. Wow. I had a meeting with the Minister of Veterans Affairs about a week and a half ago, and I briefed her on operator syndrome, different treatment modalities like psychedelics, specifically ibogaine, and then the Stellate Ganglion Block. And I asked, other than just wanting to be your friend, the bug's around, other than just wanting to be your friend and telling her to take my hand and let me help you, I asked if Veterans Affairs could put on a soft veteran healthcare symposium in the new year. I don't know, some leadway out, right? And we bring all the world expert in, and we have them do a working group with all our doctors and experts, and maybe we find out some stuff and we can move healthcare forward in Canada for our veterans. That's kind of like the big picture of what I'm going for. Obviously, what can you expect from talking to a politician? She's extremely busy, so it's not like I went in being like, oh my God, I hope she says yes. It's just I had to go in with something to present to them. So your guys' support for checking out the webinars, for spreading the word about it, they're going to keep coming. And what we need to do is keep that pressure up with sharing, having the public knowledge, spreading the word. And if you talk to someone from Veterans Affairs or someone in the government that say, hey, there's some serious treatment options that are happening just south of the border that are having extremely effective results. And we're up here in Canada listening to old Gordo talk about it and try to tell everyone. So I'm in the same boat as you guys, man. I paid $7,500 out of my own pocket to go do ibogaine last year. So that would be sweet if Veterans Affairs would pony up and we could help bring the costs down for veterans to get these types of treatments. All right, guys, on deck tonight, we got Dr. Mulvaney. He was a Navy SEAL, a U.S. Army physician. He's been published for over 10 years now in the realm of the Stellate Ganglion Block. He was one of the pioneers of this treatment modality. He is co-founder and works at a place called the Stellate Institute. This is the guy that we want to talk to. This is the guy that's going to give us the down low, and this is the professional that I know I can put my hand on my heart and say, this is good information. So with no further ado, please welcome Dr. Mulvaney.
We're going to get Dr. Mulvaney here. He's going to go over a little bit of his history, his little bit biography. And I think as he's telling us his chronological story of his life, we're kind of going to follow along and hear about Stellate Ganglion Block from the beginning until the present moment. So turn it over to Mr. Sean. Welcome. Perhaps you could let us know a little bit more than just a Navy SEAL and Army physician.
Thanks, Gordo. I really appreciate being asked to come share. And I have to tell you, as I'm going through this, I just like you, I have a lot of folks that are like, after 15 years of publishing on this and speaking at national forums and even being on like 60 Minutes or CBS News, like still people are like, what is it? What does it do? And here's the crux of the problem. The crux of the problem is our brothers and sisters in the armed services, north or south of the border. It's all the same to me. And they're killing themselves. and they're definitive. They're pretty definitive people, and if they do the work and they do the things that they're told to do, and they're still no better, they solve the problem their way, and it's really epically tragic. I was a U.S. Navy SEAL for 9 years, so I come out of, honestly, from being an operator. And from there, I mean, we always cross-trained in medicine. I always had an interest in medicine as a kid, but I was not ready to be in fluorescent spaces for the next 8 years to study medicine. So after I kind of led through some of the piss and vinegar, which never fully goes away, but still it decreased down to a level where I could sit still and study. I went to applied to multiple medical schools and got in, but I ended up going to the Uniformed Services University, the military medical school. And I went under an Army program. It was tough leaving the Navy for me because I really like living on the coast in beautiful places, and also just a lot of tradition there. But in the Army medical field is definitely, at the time and even now, was much more robust and had much more opportunity for a person that had my interests, which was basically, it was driven by taking care of the guys, taking care of our brothers and sisters, and how do we do that better? My background gave me a certain cachet, so it helped me just right away mainline in and be able to be a better doctor to figure out what's going on, knowing certain situations, but having that trust there bridged a huge gap. And so I was ended up getting board certified in both sports medicine because what I saw, our guys had musculoskeletal injuries, chronic and long-term musculoskeletal injuries that were limiting career. And then I went and did in the US, when you do anesthesia pain, then you can do interventional spine stuff. So treating lumbar discs and cervical discs and all this other stuff where I still saw our folks having these problems. And so I did that. And I did, aside from my time training or in medical training or fellowship, the entire time I was supporting special operations, with first of the 10 special operations group in Stuttgart, Germany, probably 8 combat deployments through various groups, and then other areas of SOF. Let's just leave it at that. And I, there as a physician taking care of the guys, what they valued was that like soldiers have that mindset of solving the problem or taking care of the problem that's in front of them, and not just covering it up, not necessarily doing what everybody else is doing, but really coming up with a solution that works long term, which is what we all want. We all want it. So that's what I proceeded to do. I went about going, okay, how do we return these high value assets for the mission? How do we get these guys and gals back online as soon as possible? And then how do we let them, when the time comes for them to retire, how do we let them retire with dignity and retire with still able to use their bodies in ways that they want? And so we looked at a lot of things that was going on, and I know it's about Stellate Ganglion Block, but this is all part of the path. And really, surgery and corticosteroids, I'm not saying you never need surgery. Corticosteroids for chronic injuries does not have evidence supporting its use. It just doesn't. It stops the inflammatory cascade, and you don't heal without inflammation. So really what we want to do is potentiate somebody's healing, not block somebody's healing. So that led us to, I brought first person bringing in like prolotherapy and platelet-rich plasma and bone marrow-derived stem cells and adipose-derived stem cells. Because every time I brought the problem up to leadership, the leadership completely supported it. They're like, hey, we might be able to get this guy better without surgery and have him back online 2 months sooner. They're like, do it now. So I had a ton of support to find better creative solutions. And I wasn't some loose cannon out there. I was running on the edge of the medical evidence, but it was what the published medical evidence supported. Nobody was experimenting on it. We were going, hey, what's the cutting edge safely say that we can do to heal this stuff faster? And so I did that retired after 31 years in the military. And now I'm in private practice in Annapolis, Maryland. I work with regenerative orthopedic sports medicine. And there we formed the Stellate Institute. And that's probably going to change into something with more of a training mission. So the name of it will change here probably pretty soon. But right now we're in the US, when you do official medical residency training and fellowship training, it's called ACGMA. We're an officially certified place where physicians from Walter Reed, our biggest military hospital, come and do training. so I've published 15 papers on stellate ganglion block for uses in PTSD and anxiety alone, in addition to dozens of other papers. But it's and I'm just a regular clinician. Like, I'm not some academic guy. I see patients, I see people, and when we see something that's working, the difference is that we'll actually go to an institutional review board, we'll ask for permission to do a study or to review our data, and we'll put it out there. We've never had any secret sauce. Whatever we know, we've tried to put out as best we can out in the medical literature. And then in the popular literature, we've talked in a few forums, just trying to get the word out there, because it's a real rock in my rucksack knowing that we have something that can help people. But a lot of people still don't know about it. And then, so after, I guess, there, are we all caught up? Is that my bio? Probably more than you wanted.
No. The first question I was gonna say is, damn, so you went from Virginia Beach to where were you stationed for Army practice, for your doctor practice, when you first had to go inland?
All over, anywhere from Stuttgart, Germany to Fort Meade in Maryland, Fort Belvoir in Virginia, Fort
But always
Bragg.
landlocked.
I mean, so
Yeah.
it's the Army for a reason.
I hear you. How okay, I'm gonna focus on the stellate ganglion block because
Sure.
I'm liking the other stuff. First of all, damn, we got some like serious people coming up in these webinars, so I hope you guys are enjoying it. Um, Wow, it makes sense that you were a little special forces honey badger before, always looking for work and finding it, and then you're repeating that in the medical community. And it's amazing that once you put yourself out and just ask. A lot of people don't think, like, just ask, and then you just do it. And next thing you know, you haven't been turned down, and you're progressing these treatments over and over and over again. So thank you. Thank you for being on the webinar, and thanks for being you. How long ago did you start hearing the stellate ganglion block? Because I heard about it, that it was like created for menopause, and then I'm pretty sure I had a buddy recently got it done for his back or something like that. And I'm hearing all these things, but I didn't hear about it for PTS until I was told about this specific treatment. So how long ago did you find out about it, and what's the background to it?
Yeah, and like most people, I totally remember the first time that somebody presented the notion of it, and I thought they were crazy. And I'll tell you, if you got time, I'll tell you a little story. It was I was treating one of my guys in my command, and he had just crashed his car. And so he was I was just checking him out. He's essentially fine. I'm like, what happened? He's like, I fell asleep at the wheel. Why'd you fall asleep at the wheel? I finally pull it out of him that he was taking Seroquel. Seroquel is an antipsychotic, and it's used off-label to control the nightmares of PTSD. So I'm like, what's going on? And he went on to describe, and actually it was huge in my education as a physician. He went on to describe, he had, since going back to Desert Storm, he had like bad, hardcore PTSD. And really kind of taught me what PTSD was. And he went on to describe how he was during that, even though it was brief, but during Desert Storm, he was part of that ground combat, and he was a regular Army infantry guy. And they did close quarters combat, moving through bunker systems. So he was definitely close quarters killing. At one point, a door in a bunker blew up back on him and knocked him backwards and knocked him unconscious. So an element of traumatic brain injury. And then they went on, assault through the target. After they were victorious and the blood was up, they desecrated some bodies. So there were some shameful acts involved there too. And a lot of times those shameful acts will kind of sear things into the brain not in a good way. Anyway, this is now years ago, and he's relating to me that he's still having these, post-traumatic stress nightmares. And he says, hey, I want to get off these meds. I don't want to do this stuff. I'll do anything. Just give me something that I can do instead of this. And I'm like, look, I'm a musculoskeletal and spine doctor. This is not my wheelhouse. I don't know what this is. I go, well, look, you're my guy. I'll keep my eyes open. That's all I can tell you is I'll keep my eyes open. If I hear anything, I'll let you know. And so this is where it gets a little bit weird, because on the next week, I go to some musculoskeletal medicine conference in Madison, Wisconsin, like I'm there, I'm in civilian clothes. Some guy walks up to me who I don't know at all. I know him now. I know his name's Dom because it kind of became something. Dom comes up to me. I don't know him. And he's like, hey, you're an Army doctor, right? And I'm like, yeah. And he reaches in his pocket and he pulls out a newspaper clipping. He unfolds a newspaper clipping. Like, who does that? And it's a newspaper clipping about a doctor in Chicago who was doing stellate ganglion blocks to treat women having perimenopausal hot flashes. And I'm like, okay. And he's like, hey, you think this has anything to do with PTSD? And I thought he was a little, at this point, I was like backing away slowly. I'm like, I thought he was a little crazy, right? And I was like, look, I have no idea how this could be. And then I remember that little voice saying, hey, I'd look into anything. So I'm like, all right, all right. So I go, thanks, I'll look into it. And I end up calling the physician in the article. And I just got his number, internet, and called. And like, if you ever call my office, there's not many things I'll say never about, but pretty much I'll never answer the phone. Like, I'm always busy. So I call his office, he answers the phone. I say, hey, I'm an Army doctor. I go, do you think this stellate ganglion block could have anything to do with PTSD? He's like, well, it's a sympathetic nervous system. He goes, it could. He goes, yeah, it might have something to do with it. So I'm like, okay, thanks. I go back, I see the guy in the gym. I'm like, hey, you want to do this crazy thing, this stellate ganglion block? He's like, yeah, do it. And then we did it. And then I remember, actually, I really will never forget, like on the table, right after we did it, he looks up at me and it says, I haven't felt this good since high school. Was recruited when he was a young infantryman in Desert Storm. And I thought it was just I thought it was bullshit. I was like, okay, whatever, you're maybe some giant placebo effect, something. I totally discounted it. And he was on a ton of meds. And then I was like, okay, if you're still feeling better in a week, we'll start to taper your meds. Well, before I even have time, and I'm still going, okay, I don't know what this is, but well, it seems to be he's doing well, no problem. And then a couple days later, this Marine walks into my office. He's a soft Marine, and he comes in. He's 27 years old, and he's like, Doc, can I get some Viagra? And I'm like, look, I know that was a hard ask. I'm going to give you some, but I got to do that doctor thing and figure out why a 27-year-old stormtrooper needs Viagra. And he's like, I know why. He goes, I'm taking Paxil. And he ends up, he tells me the story. He's taking Paxil, and class of drugs like Prozac, all those things are in there. And he relates that he was in, bad hard ground combat in Fallujah, and it was really intense and a lot of close quarters killing. And he came back from that deployment to his wife and 2 young daughters, and he locked himself in the upstairs bathroom for about a year until his wife had enough of it and left. Like, he just was not coping. And so he got put on Paxil as part of his treatment, but it left him with sexual side effects. And I'm like, hey, I just did this weird injection in the neck to this other guy, and he seems to be doing better. Do you want to? I didn't even get the sentence out. And he's like, do it now. Did it. And then he was doing great. And I had them tapered off all their medications within a month. They were on some hardcore meds. They were off. We slowly tapered them off all their meds. And then I didn't lose track of these guys because I still didn't believe it. Watched them for a month, 3 months, 6 months later, they're still doing great. And that's when I wrote up the first case series on the use of stellate ganglion block in military PTSD. So I wrote that up. I'm like, hey, does anybody know about this? This is kind of crazy. They're doing really well. And it got published and, through the peer-reviewed medical literature. And it was total crickets, like nothing happened. And these guys are doing great. In the meantime, I'm treating groups of SEALs down at some different areas. And they actually bring me down to their command, treat a bunch of guys, and I come do that about once a month. And one of the guys, I was treating his elbow, and some tennis elbow, whatever. And as I'm treating it, he turns to me and he's just talking to me. And this guy is one of the team leaders, a really respected guy, really extraordinary combat veteran. And he goes, hey, let me ask you something, Doc. I'm like, yeah, go ahead, shoot. He's like, I'm sitting in meetings and I'm getting drifty. And that's not me. And he goes, and I'll even see guys I've known for 10 years and I see them in the hallway and I can't remember their name. I'm like, huh. And every time they would come back from like a 4-month combat deployment, and they were just turning right around. They're 4 months home, 4 months back, 4 months home. Every time they'd come back, they'd fill out the test of the PCL-5, the questionnaire for, military-related PTSD, and they'd fill it out. And so you can predict if you're a soldier, you know exactly how you would fill that out when you come back. It's basically saying, hey, do you want to have to go talk to the psych, or do you want to actually go home? And so everyone would fill it out and they'd write down, I'm fine, I'm fine, I'm fine. And so, and he was going back into combat another month. And he said, I'm like, hey, look, this time fill this out and this time fill it out honestly. And because I was another SEAL, because I was asking him to do it honestly, he fills it out and he's frankly positive for PTSD. And I'm like, look, I've treated some of my guys with this crazy injection in the neck. You want to try it? And he's like, yeah, do it. I want to do it right now. So he did it. And then the next day he got in the car with his like 4 kids under the age of 5 on this long drive to Tennessee. And he came back from that trip and he's like, oh my God, that would have killed me before. And now he was just like, felt like himself again. He was back. He was calm and patient. And his wife was like, what happened to you? And so he stood up in front of his team and he's like, look, we're going back into combat and I need you guys to be back on your best. And he goes, this is what I was dealing with. And if you don't feel we're really ground down from a lot of these deployments, and if you're not feeling up to it, then, and what we did is we rescreened that whole team. And when they rescreened, most of them be positive for PTSD. So we treated most of the team. They went back into combat. We tested their scores after 4-month combat deployment. They were still improved from before they left. So at this point, we're like, hey, something's going on. Like, we realized it. And then we published bigger papers, a case series of 166, mostly SEALs and Special Forces guys. And then another weird thing happened. I know I'm talking a lot, Gordo, so just stop me anytime. But then another weird thing happened where it was culturally, like, SEALs were like, what, a cooler flashlight? Gimme. They just send it. So they were all like, fine. They were taking the block. They were feeling better. They felt like it was helping them a lot. And then some of the other specialized Special Forces units, they were like, hey, doc. I go, look, my fight or flight system might not be optimal, but keep me alive for a decade. And you can, because all this was going on like 2008, 2009. But can you guarantee that this isn't going to hurt me? And I'm like, wow, the local anesthetic that we used to do this, which, remind me, we got to talk about what a stellate ganglion block is. The local anesthetic we used to do this completely metabolizes out of your system in a day. I think you're going to be totally fine. And then, but we owe you an answer. And so we did something that had never been done before, which we did like 8 neurocognitive tests the day before a stellate ganglion block. We did the block, then we tested them an hour after a block, and then we tested them a week later because we were like, hey, what's going on? And we did, including like reaction time, memory, executive function, all these specific neurocognitive tests. And so what we did is, and then we started collecting data on these guys, and we never peaked at our results because apparently statistically you can't peak or they lose power. I don't know that stuff. But what we saw was that once we unmasked the data and looked, what I thought was that we weren't hurting these guys, that these guys we were doing this, and that they were going to be just how they were before. But I was wrong, Gordo. When we unmasked the data, what we saw, statistically significant improvements across the board, even in reaction time, which nothing improves. You can make your reaction time worse with a beer or drugs. You can't make your reaction time better. And even amphetamines doesn't make your reaction time better. We're making the reaction time statistically significantly improved 1 hour after a block. And and even 1 week after a block. And if you extrapolate that to the data in the medical literature on like shooting scores in police and athletic performance, those neurocognitive tests all related to that. What we could extrapolate was we had the one treatment that not only didn't hurt someone, it probably also improved their combat survivability. Now that's an extrapolation. We couldn't really say that statement based on fact, but all the tests indicate that. So and no other treatment for PTSD has actually been looked at and says, hey, are you safe? Are you safe to go back into combat active? So what are we doing with the stellate ganglion block anyway? What we're doing is we're resetting the fight or flight nervous system. That fight or flight nervous system is running in the background all the time. And it's running in the background on all of us right now. Everyone that's listening to this, we're not thinking about breathing. We're not thinking about maintaining our body temperature. We're not thinking about digesting food. These are complicated tasks, right? They take a lot of brain power and calculation power to keep your body moving and upright. And if right now the room that we're sitting there looking at our laptops, if a grizzly bear came in the room, we'd all have the same response. We'd all shunt blood, take all the blood that was digesting food, would go muscles. Even our pupils would get big to see, are there more bears in the corner? All this happens without a single thought, not one thought. It is a background system. And that background system fires immediately. And then that's it. Why is that fact that there's no thought? It's not, has nothing to do with your cognitive mind. You don't have to think about what to do in fight or flight. It just happens. Why is that important? That's important because there's a huge element of guilt. Guys and gals feel guilty because they can't just get over their symptoms. They feel guilty because of how they behave with them. Because there's a lot of ugly things that go along with PTSD, including flash anger, where you're sitting there and everything's fine, and then you go from 1 to a 10 anger over something stupid like a cup of coffee. So it's not conscious. It's not your cognitive nervous system. It's your background nervous system. And the fight or flight is part of that. And when that fight or flight nervous system gets stuck in the on position, what can happen is the body is amping the brain and the brain is amping the body, and that system gets looped. Now it's designed for that system just to burn out. Like it's not designed to stay on and to stay looped. Like picture like the gazelle running from the lioness on the Serengeti. It's running for its life. The lioness gives up the chase. The gazelle goes another 20 feet and starts grazing. As a kid, watching when I was a kid, it was Mutual of Omaha Wild Kingdom, but now it's like what, I don't know, Animal Planet or whatever. It used to make me nervous. I'm like, the lion is right there. But it's right there. It lives on the Serengeti, and it can't afford to stay metabolically. It can't afford to stay freaked out. It has to, as soon as it's not in danger, the system turns off and it goes back to grazing, rest and recover. We have the exact same system. Anatomically, we have the exact same system where we're designed to go from fight or flight to rest and recover, fight or flight, rest and recover. But anyone can get stuck in that on position when subject to like gross stress, big stressors, it can be a lot of little stressors, it can be stressors from long ago. Unfortunately, childhood stressors are super common, childhood causes of trauma, or it can be one big giant stress from combat. And physiologically, it doesn't matter. It all looks the same to your fight or flight nervous system. Your boss yelling at you or a grizzly bear chasing you is shades of the same thing. You feel like you're under attack and your body responds. What can happen though is those parts of the brain that amp the body can stay turned on, and then the body is amping the brain. Now we're used to that the brain tells the body what to do. We're not used to the fact that the body is constantly telling the brain what to do. Now this is something that you can even just do sitting at home. You can take, and and I've done this with like a vital sign monitor. You take your hand and then if you close it in front of you, nothing happens. But if you actually clench it into a fist, like not a pretend fist, like a fist you would hit someone with, you'll feel, if you're attentive, you'll feel your pulse going up right now. My pulse is going up. My blood pressure is going up. My respiration is going up. What's going on? I'm just making a demonstration. I'm sitting here chatting with Gordo and you guys, and that's it. But my pulse is still going up. My hand is telling my body, get ready, get ready, get ready. And it will not stop until I open my hand and put it down on my lap. And now my hand is saying, we're good, we're good, we're good. The body is constantly talking to the brain through this back channel, this not cognitive channel, this not thought channel, running through the channel. And this system can get stuck where the brain is amping the body is amping the brain, and it doesn't switch off like the gazelle that goes back to grazing. It doesn't switch off. It stays on. And then typically, in the typical case of PTSD, it'll burn out after a year. That system will eventually spin itself down. But a lot of times it does not. And when it doesn't spin down, and not only that, but guys and gals start feeling guilty, like with women, a lot of times I don't want to trigger anybody. I want to talk about specific things, but whatever the trauma was, they feel guilty because they can't get over it. They're like, I'm doing the meditation, I'm going to counseling, I'm doing all the stuff I'm supposed to be doing, I'm exercising, I'm eating right, I'm avoiding whatever. And I still feel horrible because they're trying to approach it a system that's not cognitive, but they're trying to approach it cognitively. They're trying to talk their way through it. They're trying to whatever. And there's a lot of things out there that can be effective, but when the system is stuck in the on position, what we do is go to where the brain and the body communication comes together right here in the neck at the cervical sympathetic chain of the stellate ganglion. And we safely, gently guide a needle down to there under ultrasound guidance. And we inject some local anesthetic around the cervical sympathetic chain, and we turn off that conversation. So then for a period of hours, the body can't amp the brain and the brain can't amp the body. And when that happens, these parts of the brain that control that autonomic nervous system all reset. They reset back down to their baseline, even if they haven't been at their baseline for decades. I treated guys, soldiers coming who were Vietnam veterans. They've been amped over 50 years. And they'd come into my clinic and we would, go through everything and do a stellate ganglion block. And they would be like, literally, like without being dramatic, they would be like sobbing with relief. They'd be like, I'm finally home. And every time, and I can tell you these things, but the power of being in the room with these people and seeing this happen like 6 times today, people that were just on the edge or stuck or considering killing themselves. It's a tough energy to be around sometimes, but it's nice to see them pull back, which
Yeah, what a huge win.
Yeah.
What a huge win. And I love the fact that I love it because I'm data driven, that there is a physiological answer behind some of this stuff, that instead of having the label, like you said, the shame spiral thing, or I call it a shame spiral, where if you feel bad that I have PTSD and blah, blah, this, blah, blah, that. But we're now finding out, hey, man, there's some things that are happening inside your body. Like you said, it's your whatever nervous system, your automatic nervous system is stuck in this position. And you're stating that it's right in the neck here. Is that like the closest it can get to that part of your brain where the fight or flight always is?
Yeah, well, it's pretty close. It's a separate channel. It's not running in your spinal column. It's running outside of your spinal cord, and it runs on both sides, down the side of the neck, below your carotid artery, below your internal jugular vein, just a little deeper than that. And we can approach it from the side, so we're going away from the great vessels under ultrasound guidance. I've done over about 4,000 of these without a single serious adverse event.
Wild.
And it's like a less than 1 out of 10 for pain. It's weird. It's your neck, but besides being weird, we can safely reach this and turn that system off. And like you said, yeah, a lot of folks, there's a lot of guilt, there's a lot of shame because of how they're behaving, but it's just not appropriate. Part of what we do is we try to help them see, like, hey, that guilt has no place here. It's like me feeling guilty because I can't make the sun rise in the west. It's just not in my power. It's just not something I can do. So yeah, so we can safely turn that off and reset it.
How long is that? How long does the block usually last? You said it's like a half day or so? And is there like complications? Like, is it gonna like make me stop breathing or something, or?
No. Usually what happens after we do a block, then 5 minutes after we do a block, we look at their eye on the side we block. So if we're blocking the right side, we look for the right eyelid to droop, the pupil on the right side to get smaller, and the white part of the eye called the sclera to get pink or red. And two people will score it to make sure that they're seeing good, appropriate changes, because that's just outside gauge that we block the sympathetic nervous system. It's called the Horner's response, but it's just, we use it as a gauge, and we have 2 people score the blocks to make sure that that person has a good dense block. And then once we see that, then they lay down for another 10 minutes, then they sit up for another 10 minutes. And then if we're feeling good, then we just follow up with them. But although the eye will be funny between, 1 to 4 hours, maybe a little longer. One of the more common, it's not really considered a mistake, but sometimes that local anesthetic will spread over to the larynx, the voice box. It'll spread over to a nerve that goes to it. and they'll get a feeling either their voice might go hoarse for a few hours, or they feel like there's something in the back of their throat for a little while called the globus sensation. And it's just because it's going numb. But that happens 15% of the time, but it will not interfere with their ability to breathe. It will not interfere with their ability to swallow. And I just warn them about it, that, hey, you might get this. And if you get this, it's going to go away and you're okay.
It
So
sounds like the risk to reward is pretty small. It sounds like it's not very scary
well,
to get.
yeah, when you're having it done by someone that's done 4,000 of them and is really
Right.
good at it. I mean, that's the problem, is it's hard knowing exactly. There's a lot of folks making hay while the sun shines out there. And unfortunately, some physicians have done 10 and they're doing this, and they're looking at a complicated neck, and some have done thousands and they're looking at a neck. There's going to be a different level of competence going at this. So I would like it if everyone did a good block, but unfortunately, I hear lots of stories about people. That's my worst case scenario, is somebody goes and they go to get a stellate ganglion block and they get one and it wasn't technically competent, where they didn't get a Horner's or they didn't get the response they needed. And then they're told even by the physician or the provider that, hey, well, sometimes you just don't get that. And that's not true. If you do it right, you get it. And then the person leaves there feeling like, okay, stellate ganglion block doesn't work, or it doesn't work for me. And that's too bad. And the way that we work around that is we have 2 people score every one of our blocks. The low score wins. And if the score isn't good enough, then we'll put some more local anesthetic in until we get a good block. If for some reason we don't get a good block, I wouldn't charge somebody. But
Right.
that doesn't happen. Actually, it happened one time. It was in a bad head wound, and it was because their sympathetic nervous system wasn't hooked up on that side. But aside from that, gross anatomic variation, we get Horner syndrome in people. So I think that's the important thing, is if you go get a block somewhere, you should see your eye definitely go funny. It should be like the guy from Jiffy Lube can call my blocks. Like, it's just, anybody should be able to look at this and say, that eye looks
Okay.
weird. It's not some doctor's secret whether or not you got a block. And
Right.
then, and then we look for, okay, then, what happens and how do you feel? And you also have to spend time explaining to people what's happening. You have to, kind of, I don't know. I don't know any way to not spend time with people, because to explain what's happening and put them at ease. And then after things start happening, because after you do a proper block on someone with PTSD, things start happening. Now it might take minutes, and some people it can take up to days, but people start feeling, I usually look for some kind of profound calmness coming over them, parts of the body that are tight that are now relaxed. There are definitely signs that show that, this system is unwinding, I call it, or uncoiling. And it's pretty dramatic when it happens. And it's kind of nice to be able to see that as part of your day to day. So
Yeah, no kidding. It must be extremely rewarding. The
yeah.
I guess like the elephant in the room for me, it's like, what is the holdup here? Why isn't this not like your Stellate Institute is turning into a training facility? So me reading between the lines, you're trying to make this more of a normal thing.
Yeah.
Why isn't it a normal thing? Why isn't this like the first line of treatment for even coming back from deployment? You do your screening, boom, boom, you get a SGV, you're good to go.
Yeah, I mean, that's a great question. And usually what happens is policymakers hide behind the need for more evidence. Well, we have what was called level 1 randomized control trial. So we did a stellate ganglion block versus a fake stellate ganglion block. And we did that over in Germany and in Fort Bragg and out in Hawaii. And then we gathered all that data. I mean, it costs a couple $1 million to run a study like that. And we published it in JAMA, and we showed beyond a shadow of a doubt, hey, when we do a proper stellate ganglion block versus a saline injection, a fake injection, that we had people were doing much better. And really the results are even more dramatic than that. There's over 30 papers in the medical literature, the peer-reviewed medical literature. Anyone can go to like pubmed.org and just type it in, PTSD, SGB, and these papers will come up. I've written about 15 of them. And what we see is that, hey, results in a durable relief, but they'll be like, we don't want to pay for it, or we don't want to change, our indications for this. Right now, stellate ganglion block has better indications than almost all other indications that it's paid for by insurance companies, whether it's chronic regional pain syndrome or Sometimes they use it for migraine headaches or other sympathetically mediated pain, it's called. But we have good evidence. And then even you could look at the US's own Veteran Administration and say, hey, why are you guys not offering this? And the VA really is, in the US, is a series of fiefdoms. They all kind of do what they want, but some of them are offering it as a potential treatment, usually not at the scale that's needed. And a lot of times, hopefully done by someone that knows what they're doing. But, I think that there's a quality spread there too. And then, but in other words, we're putting the evidence out there, and we're hoping that it takes, if anybody's, feels like they want, I mean, we're here in Annapolis, they just have to call the office, and we book people in. Even in the US, the insurance companies don't cover it for that indication. So
It's so crazy.
Unfortunate. Yeah, it's unfortunate, but then again, if somebody's really on the ropes, and usually with US veterans, we can we have different organizations, nonprofits that'll help pay for their treatment. We a lot of times we'll have money available, but a lot of times we don't have money available, but we usually figure it out.
That's a big part of the webinars is getting the information out to bang the donation drum. Like, I just don't think people are hearing about this stuff, and the fact that there is access, and yes, everything costs money, but like, what is money when it's your life? So,
Yeah.
I'm gonna get to some of the questions. I think that kind
Sure.
of brings us up to speed, because there are several questions. We're in respect, your time this evening. We got about 14 minutes left, so we'll do it pretty quickly. The success rate, I think I covered it in one of the posts. I think there was a 6-month success rate. That's like the most astonishing part. Is that what you were touching on earlier?
Well, here's the deal. What I tell people is 1/3 of the people we treat are one and done, and then 1/3 can retrigger. They may know what retriggered them. They may not know what retriggers them. Generally speaking, we have a strong response rate out to 3 months, but then life can happen. If I fix an NFL football player's knee and he goes back in the season, he just might hurt his knee again. So life is a contact sport. So it doesn't mean that we fix it and it's done forever. But in a lot of cases, it is. We just reset it. Now, some people will have ongoing stressors. So what if you're living with the person that's your tormentor, or you're living with the person that's your stressor? Or what if you're going through like an ongoing situation, a legal proceeding or something that's bringing all these things to the fore every day? Hey, they might take a couple treatments, but for most people, what we do is we do one, and then we see, okay, how are you doing? And we follow them out for a month. And then if their symptoms come back in the future, first we tell them, hey, don't feel guilty about this. It's nothing that you should feel guilty about. If you retrigger, you retrigger. But if they come back, then it can safely be repeated if it needs to. I don't set the expectation people need more care. I'm like, let's see, maybe you're good. And a lot of people are. And
Yeah, I think maybe that is kind of this conspiracy talk about the system of care, of like, do we actually want to get these people fully ready to go, or do we want them just sick enough to have to take treatments? That's
I
big
don't know. I mean,
conspiracy talk.
any
Sorry.
policymaker wants tax-paying citizens, right? So I don't think anyone
Right.
wants to hold back, let alone veterans, from, being able to be good parents and be good providers for their family and be good productive citizens. So I don't know about that. One thing that we did learn,
Sure.
I do want to touch on, we have a paper that's coming out. It was a study, an institutional reviewer approved study, where we looked at traumatic brain injury. In traumatic brain injury, there's not a lot of great treatments on, but when we did bilateral stellate ganglion blocks, so on one day we did on the right side, the next day we did on the left side, we saw using the NSI, the Neurobehavioral Symptoms Index, which is the standard kind of questionnaire that the VA and the Department of Defense here in the US use. When we looked at those scores, we had a 50% improvement across the board in those scores out to 1 month anyway. So we're seeing, hey, there's probably some other applications for that. So we have research on that. We did a case series of 300 folks on just anxiety. Anxiety, all told, and anxiety, we were reducing it by half. So we're seeing some other applications for this. It's not just for PTSD anymore. Anyway, let's get to the questions.
No, you're good.
Chat. I'll
What
just keep chatting. I'll just chat.
It's fine. What's the normal cost associated? What should we expect as a roundabout number?
For military, it's usually about 900 per side.
Okay, that's really
And we usually
reasonable.
try to get that paid for. And we honor Canadian military service. So, and then if it's also another discounted rate for law enforcement. If someone's just, civilian unaffiliated with law enforcement or EMS, the cost is 1,200. So
Okay, that's still really reasonable. I can't believe it's this cheap. Like you heard in my video how much money I spent to go do ibogaine, and it's like,
right.
damn, this is just it. It makes sense. Next question. Would stimulating the vagus nerve prolong the cognitive improvements seen from the data you mentioned previously, or impact the effects of the SGB in any way? Specifically, things like heart rate variability, biofeedback training, or breath work. Example, down regulation strategies.
What we see, and this is unpublished data, but we see people's heart rate variability improve after, because there's enough of my patients have Oura rings or Whoop bands or whatever. So we see improvements in heart rate variability after stellate ganglion block. Doing specific research on vagus is actually really interesting. It's one of the things I keep looking at because the problem is the vagus nerve runs really close to the stellate ganglion. So you could argue and say, it's really hard to block just one. So are some of the effects that we're seeing from blocking the vagus anyway? Could be. So I allow for, but it's really hard to block just one because they're close to each other, the local anesthetic spread. So we're probably getting an element of a vagus block. Now, sometimes for certain conditions, for certain conditions in the gut, for certain inflammatory conditions or rheumatologic conditions, we do target the vagus nerve, but that's anecdotal. And in other words, that when I say that's anecdotal, when a doctor says it's anecdotal, it means it's just based on my experience. It's not really based on good peer-reviewed published data. But that's another one of those projects that's in the works. I think that there's clearly your caller is, I mean, the person sending the question is pretty astute. So do we think it'll help with heart rate variability? Yeah. Do we think that adding the vagus is beneficial? Yeah, but we think we might already be adding the vagus. So that's a little bit harder one to tease out. And I know I do more of these and know more about this than all but a handful of people. And so, and we're really looking at this question. It's just a tough question, but their question is it's a good question.
Cool. Sweet. Thank you for the answer. Thank you for asking that question. It was super hard for me to read. I appreciate it. I'm joking. Okay, my husband and I are receiving the SGB in Tampa the first week of June together. Shout out to All Secure for making that happen for us. How does the SGB affect energy levels? The second part was how does it affect someone with multiple TBIs? I think we hit on the TBI portion just recently that you guys are looking into it more because you're seeing cognitive improvement. So we'll just go with what are the energy levels like?
Well, I describe it as if you've ever worn a heavy backpack, a heavy rucksack, right? And you've worn it for a long time and you take that rucksack off, you take the kit off, you take the body armor off. How do you feel? You feel like you're floating, right? You feel like you're literally going to just float right out of the screen when you take all that gear off.
The best.
And when you reset the fight or flight nervous system, you're taking away all that noise. You're taking away all that background energy that's just eating you up. And so when we reset that to its baseline levels, to its normal levels, people can sleep better. They get better deep sleep. The quality of sleep improves. We see that on our Oura Ring data. And with that, their energy levels correspondingly rise. You're taking that rucksack off. And so you can run faster without the rucksack on. You can sleep better. Your energy levels, improve a lot. Now, do I have any kind of true qualitative or quantitative data on that? No, but that's what we see.
They're going to be enjoying Florida with sweet energy levels then. Do you have any recommended providers in
After
Canada?
they get the block, they're going to be tired as crap. I mean, after they get a block, they're going to want to go home and sleep. People sleep like all day and all night. I mean, They really, so a
Mm.
lot of people are really tired after that release happens. Yeah, they'll want to sleep. So don't plan a quiet day for the day you get it. And then,
That makes sense.
and then our protocol now is we do the right side one day and we do the left side the next day. But we didn't see benefits with TBI because for the longest time, we were just doing the right side. But once we added the other side, that's when we saw the benefits happen. And a lot of that came about with some research with long COVID. Long COVID symptoms are improved, the mind fog, a lot of the symptoms associated with COVID. Now there's separate research on that, but when we saw like, hey, you need to treat both sides of the brain. If garlic smells like poo and you only treat one nostril, garlic's still going to smell like poo, or onions are still going to smell like poo, which is I'm saying that's a common complaint with long COVID when they have the change in smell symptoms.
Oh, okay.
So
Sorry.
if you treat both sides, then the symptoms improve. So the fatigue and the mind fog, those are two of the biggest ones that improve with long COVID, but you have to treat both sides. So we're seeing a lot more effects now that we're doing two sides more routinely.
With the two sides, I've heard, I'm going to steal a question. I'll ask one more question after this, and then I'll shoot you an email with the other questions, and we'll get those answered for people. I heard that the left side is more adapt to like childhood trauma or like long-term trauma. Is there data behind that?
No. What we
Okay.
see is it's really hard predicting who is going to. I used to spend a lot of energy trying to predict, should I block the left side or the right side on somebody? And now what we've, in one of the papers we published, we showed, hey, when we treat both sides, when we treat the right and then the next day the left side, we don't do them on the same day. I consider it to be unsafe, because if you get that globus sensation on both sides, it can be very distressing. So we do the right side one day, the left side the next day. Because what we saw was in the one published paper that we did on anxiety is when we did both sides, we had better results than we just treated one side. So, and then what type of trauma is stored where? Embryologically, the sympathetic nervous system or the fight or flight nervous system is more associated with the right-sided stellate ganglion block. That's why that's where we started years ago. But what we see is there's just a lot of crosstalk, and then it comes down to the individual, and then you don't know. Some people are going to respond predominantly on the right. We know we published a first paper that shows, hey, 1 in 20 people only respond on the left. And we didn't know that. So every now and then you do a right-sided stellate ganglion block on somebody, they wouldn't get any better. But what we saw was typically it was additive, right? Added to left. And then we did that. If somebody's flying in or coming in for a treatment, you're not going to leave them dangling. You're going to get that other side no matter what. So I don't spend a lot of effort trying to figure out which type of trauma is best treated on what. There may be some arguments for why the left side might be more valid in childhood trauma, but I don't know if that data is not very strong, and it may actually be wrong. So I think that really what we would do, whether it's whatever flavor of trauma, it is physiologically very similar, and we treat it by blocking the sympathetic nervous system, one side and then the other is the preferred way of doing it. Now, if somebody knows, hey, I really only respond on the left side, then fine, we'll just do the left side. But then the dirty little secret is your brain is neuroplastic. It keeps changing. So just because you responded on the left side doesn't mean you're going to keep responding on the left side. So I think a little humility before a really, complicated system is kind of essential, and not thinking that you've got things wired or down. I just understand, like, hey, observationally, I'm here to listen, to see if I see something that's helpful, we write it down. But what is going to work for a person is what's going to work for the individual. That's hard to say. But if you can proceed forward in a safe fashion, then we'll get there.
Right. Keep going. Keep going. That's like the main takeaway. Keep going. There's lots of treatment options. Do you think I can sneak one more in before we let you go?
Oh, sure. Yeah.
Okay. It's interesting because I'm interested to hear. I have a bunch, so like I said, guys, I will make sure that I get answers to these. The last one we'll do is what are the benefits of combining ketamine treatment with SGB, and have you heard of that? Do you have an opinion on it or data on it, I guess?
I know of no published study on that. I see a lot of people looking to give value add by doing ketamine. And here's the problem. I'm trained in anesthesia pain. We would run, when somebody says they got ketamine therapy, and we would do ketamine therapy for things like central pain. And when we do this, we had 5-day ketamine, 3-day ketamine protocols. Even our 1-day ketamine protocol, they would come in, they'd go into a room in the ICU, we'd turn the ketamine on, we'd put in an IV, turn the ketamine on, and then we would keep increasing the dose until literally their eyes couldn't focus. Their eyes were having beats of nystagmus, it's called. Their eyeballs were bouncing back and forth. That's a pretty heroic. Ketamine's a very safe drug. We would give high doses of ketamine, and we would, once their eyes were flickering back and forth and they were kind of like a little bit catatonic, and then we would just keep it at that level for the next 6 hours. And then some people go in to get ketamine and they get like a little IM injection of ketamine. I don't know what it does. So in other words, when people say ketamine, it's like saying I went to a restaurant and it sucked. Do you go to McDonald's? You go to Hortons? You go to like Chart House? You go to some nice place? I don't know what they got. So when people say adding ketamine, I'm like, whoa, there's a lot of variability in that statement. Do I think ketamine's safe? Ketamine's safe. It's an anesthetic for children. I mean, and we use it in combat when we're doing combat anesthesia because it's stable for blood pressure. It's a fine drug. But what I see is every now and then I see somebody say, hey, ketamine was a game changer for me. But what I more often see is they were like, yeah, while I was doing it, I felt a little bit better. And then it seemed to be for a few days after that, but it didn't seem to be a big bang for the buck. Now, and I'm a doctor that does ketamine therapy, or I don't do it now for PTSD, but I'm trained in it. I did it. I have no beef with it. And I just see a lot of my patients don't get a lasting benefit from it. So, and then also there's a lot of variability in what ketamine treatment is and what people are selling as ketamine treatment. I'm sure they're getting some ketamine, but are they really getting the dose they need to make the response, the changes? And that's something I don't know. So what I would say to people that already want to jump to like combo therapy is, hey, why don't you try a treatment that's safe, that has a lot of good published medical evidence on it, and see if that works for you. If it works for you, maybe you don't need all this other stuff. If it doesn't work for you, hey, next, keep on moving. And I mean, I have no beef with psychedelics. I think a lot of them are safe, but they don't have a lot of medical evidence, going through some of the medical evidence from the 60s that they had is at least promising for safety data. But does this result? I know lots of people that have done psilocybin, and they're not all little Buddhas running around. They're not all enlightened creatures. So I think that a lot of these drugs should be used in the setting of a therapeutic relationship. So somebody, a practitioner that's skilled in, hey, how do I guide somebody through a psychedelic session in a safe fashion? How do I keep them safe and hold space for them? I think that they have a lot of potential, especially for, we talk about PTSD, but then there's another little cousin, which is called moral injury. Moral injury comes from what you did wrong. And a lot of times in combat, we're not all little angels, and when the blood's up, sometimes bad things happen. So sometimes we do bad things. And so once you've done something that's wrong, it's hard squaring with yourself with that opinion that you're a good person. And to do that, you're going to need to form new connections. Well, guess what? Psychedelics they've been shown in PET scans and functional MRIs, they're good at forming new connections. So if what you need to do to get back to whole is to form new connections on your self-image, or help you square with the things you actually did, that can be really useful. And that may hold a lot of promise, but we don't know, and we haven't done the research. It seems to be pretty safe. If it's done in a therapeutic relationship, I think it has a lot of value added in that setting, rather than just going, well, I'm gonna try this, or I'm gonna go out in the desert and puke my guts up on ayahuasca and see what happens. And I know whole SEAL platoons that have done that. My people, and they're like, yeah, it was really helpful. Great. I'm glad that it was really helpful for you, but we got to get something written down on this. We got to know what's safe.
Right.
What was the dose that you got? How did all this go down?
The
And
restaurant reference. We don't
right.
know how much, and we're all so different. Yeah, I like to lead
You would
with
process the
like
same
lead with
dose of
that.
ketamine or same dose of ayahuasca different than I would.
Right. No, there's been a couple things tonight that have really keyed off for me. The restaurant analogy. What restaurant did you go to? You don't know. Everyone's body's different, and I think this is when we first got on before everyone else was here, is that I really saw this as like a progressive way of treatment that like, hey, the data's there. There's very, very, very little side effects. So it should be, let's start here and then progress, like you said, and keep going, because there are lots of treatment modalities and there isn't any reason for guys to be suffering or females to be suffering. It's there's lots of options. Um, I want to thank you. I really, really want to thank you. I'm gonna get the questions answered for everyone here. I'll be pushing more posts up on the Stellate Institute. I think you're going to be hearing from me to get to go down and check it out for myself. It's such a reasonable cost for self-care. If you are a medically released member or you're going through it, I know you're going to get money from Veterans Affairs for your injuries. Maybe squirrel a little bit of aside and take care of yourself if that's what it takes. That's what we'll do for now. And up until that point, we'll keep beating the drum, letting everybody know what these treatments are, especially the Stellate Ganglion Block. Everybody, let's keep pushing that good energy. Dr. Mulvaney, thank you so much for coming. I hope that was good for everybody. It was fantastic for me. I feel very full on information.
Man, I really appreciate it. Anybody that's out there helping push this information out. You're helping your brothers and sisters. This is exactly what we're looking for. I couldn't be happier to be here, and thanks for asking me. Sincerely.
I appreciate it. Let's we'll talk soon, the next couple days, and bye for now. See you, everybody.